Research is the soul of medicine. It is the one thing that ensures the healthy existence of humans, even animals, as well as plants. And that is why the continent must come together to pool its best brains and resources to ensure that it fights and understands COVID-19. Welcome to VSA. I'm Sulaiman. Well, basically, that's the essence of research, which is the most basic requirement for the healthy existence of humans, animals, plants. Without it, many solutions to age-long problems would never be discovered. Africa is believed to have enough brains, mind, and resources to engage in trouble-alleviating research, but the will and desire may have been absent. Well, as the distribution of COVID-19 vaccines take a controversial turn, now is deemed the right time for Africa to solve its problems. And that's the whole essence of our conversation today. We started off yesterday, and this is just the point where we welcome our guest again on the show. Joining me from the United Kingdom is Dr. Peter Imoesi. He's a research fellow at the University of Aberdeen. And of course, Dr. Matoke, who is the Deputy Director at the Kenya Medical Research Institute. Good to have both of you join us again. A lot of Africans were excited to note quite a number of things. Vaccine nationalism has become a topic in the world, and African countries are not left out as affiliations have begun to be the main factor in sourcing for vaccines. So there are fears that Africa may be sidelined in distribution of vaccines, with the high-income countries getting more than 39 million doses at the point in time, while the paltry 25 have gone to the lowest income countries. Former Liberian President Ellen Sirleaf Johnson has said they've been left, quote, disappointed and discouraged with the distribution of the vaccines, as she chairs the Pandemic Review Committee of the WHO. Let me start very quickly here with you, Dr. Matoke. The conversation yesterday has been about understanding the strain, and also putting in perspective the type of vaccine that the continent needs at this point in time. Perhaps let's start by looking at some of those key issues we left off yesterday. And one of such is about research funding, which is very, very key. I want us to start, looking at that much more deeply and see where we're headed. There are different tales coming out of the continent at the moment. And recall Okonjo-Iweala did say that African countries will receive the vaccine in February, which is just about 2 weeks from now. So, and of course, Sirleaf says Africa won't receive it until 2022 or 2023 under the current arrangements. Are there things the continent should be doing at the moment to ensuring that we can get our own, vaccine for the continent and even helping other people of the world?
Yeah, thanks once again. I'm glad to be back here to continue with the conversation that we started yesterday. There's a lot that the African continent can do in order to be able to develop or come up with a vaccine that is for the control of COVID-19. Among the measures that governments should be doing, even as we look forward to either, because we know that most countries have placed their orders, they are soon to start either vaccinating their population. Among the things that needs to be done is apart from just buying the vaccine, we need to look critically into how can the continent be able to also develop a vaccine that is locally produced and locally tested. Even apart from that, because we need to consider issues of sustainability, the ability of us in the continent to have a vaccine that is readily available to us, something that is cheaper, because
Well, I'm afraid I think that there's a glitch there. Let's quickly go to Aberdeen, where Dr. Imoesi is. Let's bring in the talk of, what they call vaccine nationalism, Dr. Peter. Countries are already using relationships to source for vaccines. Are there dangers in this?
Thank you for having me once again, and it's good to be back here to finish off from where we left things yesterday. And when it comes to vaccine nationalism, it's a little bit tricky, right? So, for instance, if I do have a wide range of family, what you expect I would do as a reasonable head of the family is to first and foremost ensure that my own family are satisfied first, before I then go out to give my assistance to the neighboring people in the village, cities, and town. But that's on a different level entirely. But when you look at the vaccine itself, and look at the virus knows no bound. So it means that if you're right there in Lagos, within 24 hours, you have that particular virus here in the UK. So that's where you then have to work with this collaboration by the WHO, whereby the vaccine should be evenly distributed. And a case example is like WHO were initially saying was that first we need to consider the health workers' rights. Then after that, you look at the elderlies. So for instance, in the UK, I think we vaccinated over 4 million. And in Israel, I think they've done over 10 million. Then I think in Europe, they've done somewhere 10 million or so. But when you put this into context, what is the population size of health workers in this country? Are they up to 10 million, for instance, in Israel? Are they more than 4 million or 5 million here in the UK? Are they also more than tens of millions in the US? And that's where the issue is. So it means that somehow or somewhere, these countries are actually vaccinating almost all of their people, whereas we should be able to share this vaccine across all countries in the world, where the frontliners who have been there for the last 11 months should get a shot at this particular vaccine first. Then after that, we can then decide to go ahead to look at the elderly. And that's why we said initially that we need to adhere strictly to these non-pharmaceutical interventions. For instance, here in the UK, we have care homes where people are highly restricted going in there. Say, for instance, if I'm to visit a care home, for instance, or I do have a family in care home, I'm not allowed to come in at all because I'm regarded as a risk individual, high-risk individual. So it means that we have measures in place to cater for these individuals going forward gradually. Then we should be able to give this vaccine to people that are actually on the front line. And I think the world right now, it seems that all man to themselves, that's the way I see it right now. No one cares again. And if we forget that we are humans, and this is a human race, and this is a global pandemic, it all started in China. And here we are across all the entire countries in the world fighting for one cause, which is the COVID-19 disease. So I think we should go back into the drawing board. Then we should be able to say, you know what, let's distribute this thing accordingly. Well, I think that should be a challenge for African countries, basically.
Because I think you painted a very grim picture there, because once it was just on television from across the world, everyone looking to China, but now is well upon everyone and even on the continent. Now let's take this back to the laboratory. Based on science, can the mRNA type of vaccine change one's DNA?
So The answer is no, a capital no. So the mRNA type of vaccine is for the full meaning of mRNA is called the messenger ribonucleic acid. It's actually a genetic material, but this genetic material is highly unstable. So what that means is, if you have an mRNA right now, right there in your studio, it may likely not survive more than 6 hours. That's how unstable it is. Now, if you also introduce that mRNA into an individual, in your system or in our system, we have what you call nucleus. Nucleus are enzymes. Consider them like scissors, or you consider them like scissors. So once a foreign body like RNA, for instance, is introduced into an individual, what your system does is to release these nucleuses to immediately degrade that particular component in your system. So what we're trying to do is then you then have what you call the lipid nanoparticle, which is a little bit funny because people have heard about nanoparticle. All of a sudden, everyone is going haywire. Oh, they're trying to change our genomic system with a nanoparticle, etc. Basically, what the nanoparticle does, which is a lipid nanoparticle, is to help shield the mRNA to keep it at a stable level, and at the same time to enable that particular mRNA to be transferred into the host, in this case, the human host. So what you have in that particular mRNA is just a little fraction of the spike protein. So the spike protein, like I explained yesterday, is the area of the virus that it uses to gain entry into the human host. So we're trying to just take a little fragment, create an RNA, then infuse that RNA into a lipid nanoparticle. Then from that particle, because the human body, you have lipid layers, you want to be able to transfer that particular RNA that has the spike protein in it into the human. Once it gets into the human body, for instance, in the cell, the RNA is then released. Once the RNA is released, you have a kind of, so the way the cell looks like, it looks like a ball, a cycle. In that cycle, you have a little dot at the middle. That dot at the middle is called a nucleus. It is the nucleus that warehouses the DNA materials, whereas this particular messenger RNA stays outside of the nucleus, which is the cytoplasm. Now, in the cytoplasm, once this particular RNA comes in, it binds with a particular location of your cell that is referred to as ribosomes. That is where you make your protein. So what this particular messenger RNA will then go ahead to do is to use the machinery within that particular ribosome to make more proteins. And once the protein is ready, it will out of the cytoplasm to then create a system that will then lead to antibody production. But once that RNA is done with in the cell, it is degraded immediately. So from the point of molecular biology, there is no way that particular mRNA will get into the human nucleus where you have your DNA. And for you to change an individual or for you to change an organism, you have to start from the level of DNA. And that particular DNA is well guided. So there's no way you get things inside so quickly.
I think so, that's the word. The DNA is well guided, because I'm quite sure maybe also in Europe you must have heard some people arguing that it just might interfere with your DNA, and a series of conspiracy theories abound, making people to ask such questions. But again, looking at the distribution of the vaccine on the continent, which is uneven, at the moment, for some countries like Nigeria, it is yet to get. Many African countries can't even afford these vaccines. Maybe some have also been sidelined. So what's the next thing for such countries? Are we looking towards local solutions?
First, I think this should bring up the real challenge, right? For African leaders to sit tight, to say, from now on, we need to put our house in order to ensure that we're able to do our own things ourselves. If you recall, in the early days of this pandemic, people were saying the West are trying to depopulate Africa, right? So if you want to go by that particular speculation, then you should be able to go back into your own zone to make your own things for your own people. But so long you lack the capacity to do that, maybe due to corruption or due to less expertise in the continent, then you have to depend on this individual. But what can we do for the time being? Since recently there is I think we have 2 rapid diagnostic test kits already approved by the World Health Organization. And those particular test kits will verify that they are actually functional in Nigeria. So what we could do right now is, going forward, as we kind of discharge people from the isolation center, this is not in Nigeria alone as well, across all African countries, what you could do going forward is start to monitor the antibody of these individuals. So say, for instance, you discharge about, let's say, 8,000 people today, take their blood sample and test for their antibody level. Then a month after, you call them in again, you do the same thing. Now, what you're trying to do is you're trying to check if your population are gradually building up that immunity you need. Of course, that same immunity is what the vaccine confers to individuals. So since people are trying to play hide and seek now, or I don't have, you have, I have, you don't have, then if, for instance, let's say a country like Togo, we have to wait till 2022 or 2023, then you should go in here and start doing this little but basic research within your population to see if within this time lag of about 2 years or down the line, if your people are gradually building up the antibody required. So those are for individuals who are within the isolation centers that are being discharged. That is one arm of your research. The other arm of the research you could look at basically again is to ensure that if people are admitted and they are asymptomatic and their cases are not so severe, let's say they are mild, what you could do is you could create a table for people who have mild symptoms, for people who have severe symptoms, then you compare their antibody. And for people who are asymptomatic, you also have a table for those individuals. So over time, you start monitoring the antibody level of this individual. You may not be surprised that the people with high level of this virus, which are severe cases, may likely have a reasonable level of antibody compared to those with mild and compared to asymptomatic individuals. So with that, you start creating a database of people in your country that are actually generating this antibody gradually. Now, if you monitor these individuals for over 6 months, you have a clear picture of your population, who is actually generating this antibody. Now, going into the large public, for instance, I had Lagos State Governor recently saying that should you present any symptom of malaria, your first point of call should be a COVID-19 test. Now, if you want to go ahead to say you don't want to do a COVID-19 test, you must do a proper malaria check. So what it's trying to do is really good. So first, if everyone present themselves for antibody check, for instance, since we now have the rapid diagnostic test kits, what that implies is we are going to have a chunk number of people that may likely have this antibody going forward. And that we kind of relax the pressure we have on the continent. And to finish off is basically, like I said some time ago on your program, I was saying that the vaccine is not so urgent for us, because when you look at the situation in Africa, we're not really reporting high number of fatality. So it means that we still have a little coverage over our people. So if people are unwilling to give you the vaccine, just ensure that you adhere strictly to the non-pharmaceutical intervention while you do your antibody research gradually over time to know where you are with people with this particular antibody against SARS-CoV-2 virus.
You know, listening to you, the whole essence of this then means one thing: the importance of research. The scientists must work, side by side with the doctors and every caregiver in order for us to have a better understanding and find a final solution to all of this. When we return after now, we'll be looking pretty much more about the possibilities of the continent producing its own vaccine and how local pharmaceuticals or even government can be of help. Join us again. Well, for some reasons, I think we lost the connection to Nairobi, Kenya, where Dr. Matuke is. We hope we can reconnect, but in the interim, we're still with Peter Imoesi. And Peter, quickly here, because we're trying to understand how it works, perhaps as researchers, what are the possibilities of having an Africa-produced vaccine by local pharmaceuticals or even national governments?
There are quite a number of possibilities for Africans to be able to develop their own vaccine. And I think that is Senegal in Dakar, is actually vaccine production for yellow fever. It's just that that particular system is not the same sort of system for the SARS-CoV-2 virus vaccine that we're currently developing. And I think as well in Egypt, there's also vaccine production. But the point is, if you're trying to delve into the production of vaccine in the continent, it's not something you just wake up overnight to do. So first and foremost, it's not enough to have the required tools and machineries. You actually require the human capacity to be able to do such high-tech research. So I will give you a clear example. In the early days of COVID-19 in Nigeria, we had issues of people inability to carry out COVID-19 tests at the level of RT-qPCR. And in that particular early days of the pandemic, we're actually running around to train people on the job, on the go. So you can see, even though you have the required tools, you have the required machinery, you actually need the human capacity to be able to develop vaccines that are kind of beneficial to your own people. So going forward, we should have, let's say, a 10, 15, 20 years plan to actually start to develop our own research and development platforms where people could easily volunteer or get employed to produce this vaccine that will be beneficial to Africans. And by then, we will be self-dependent without relying on the Western world for every single drug development that has to do with people on our continent. So I think first, let's invest massively into training and retraining of African scientists. Then after that, you go ahead to build this infrastructure. At the same time, you need to set up collaborations. So it's not enough to go ahead to do things all by yourself. The world is a global village right now, so you could easily connect with scientists around the world, both Africans around the world. And from there, you could have these people come down once in a while to train your own people, to teach you how to run these facilities going forward. But vaccine production is not something you start today and get results in the next 24 hours or the next 24 months. It's going to take time, but we have to be deliberate in our efforts.
And does this also work with what you highlighted earlier, talking about those who have been, cured of the virus, those who were down with the virus but now have tested negative, keeping an eye, as you did say, on these people? Are there things that scientists like yourself can get, especially in the making of a vaccine for the continent?
Yes, so I think in the early days, even currently as well, people do get serum from people that have recovered from this particular disease to people who are severely hit in a isolation center. So what you're trying to do is you're trying to create antibody immediately for this individual. So that is a little research that is so small, cost effective, that anyone in Africa or in Nigeria could actually do, basically. So that arm of research when it comes to antibody development, like I said yesterday, there's already established publication here in the UK where over, I think, 11,000 participants were tested. And among these participants, the majority had close to 62% of antibody in their system. Some had up to 92% in their system. That shows you that actually, if we go about our business with this antibody research within the country or within the continent, most likely, majority of Africans may likely have developed antibody over time that we're not aware of. And if you have this population of individuals, that you have this antibody development already, it may likely save you the stress of worrying about vaccine in the immediate, but on the long run, you actually go for vaccine as well. Again, what we could also do again is this. If you look at the situation in Nigeria, for instance, the level of individuals who have mild symptoms or who are asymptomatic are much, much higher than people with severe cases. So what you could do is, for instance, if you admit an individual, you could ask this individual in the last 3 weeks or the last couple of days, what medication have you been on in the last couple of days before you are admitted into the isolation center? You take note of those medications that individual is going to roll out to you. Then if you admit the next patient again, you ask similar question. Then you then watch the recovery time of those individuals who had some form of medications before they were admitted into the isolation center. If there is a fast recovery rate among a set of people that have used a particular drug, that gives you a clue of what drug you could actually be looking at for people to take going forward. So that is another arm of research that we could actually do, because we are aware that in Africa, specifically in Nigeria, people are into self-medication. It is when the issue is out of hand, they call for help. So when such people call for help, ensure you get the required details. So with that, you will know the common trend of drugs that are currently being used by Nigerians in the country. Then from there, you could invest your resources to actually look into this particular drug to see how beneficial those drugs could be when it comes to the treatment of COVID-19 disease. So those are the bits and pieces of research we could be doing before we have full access to the vaccine going forward.
Does it also worry you to see that as Africans, think that come up with this, myth going around the continent on how the West intends to depopulate the continent? You also see some educated, minds from across the world, way into such, kind of argument. So why then is Africa yet to develop its own, vaccines, or perhaps government speak up against those who thought that this is just about depopulation of its people?
That's a really brilliant question, right? So if I pay you a visit, then someone says, if you go to Alega's place of residence, it's going to poison you. Then I still go ahead to visit you, then eat with you, drink and marry, and still go home. That's me being stupid, right? So if you're saying that a set of people are coming ahead to depopulate your continent, then, like I said initially, it gives you the challenge, like, oh, let's take this on. But to say the least, I don't think there's anyone out there trying to depopulate the continent or anywhere in the world. If that is the case, so what then will you say about Israel, that have actually vaccinated over 10 million of their population in the last couple of few weeks? And secondly, I think if we really want to go about the acceptance of this vaccine, Nigerian government or any government in Africa should start speaking to religious leaders, advise those individuals to volunteer themselves to take this vaccine. In the last couple of years, I've realized that Nigerians are more in touch with their religious leaders and traditional leaders compared to the government. So take, for instance, if the Sultana of Sokoto makes a proclamation today and says, oh, I've taken the vaccine and the vaccine is safe, just imagine the level of impact that will go in the country. But if somebody in the government says, oh, I've taken the vaccine and the vaccine is safe, Nigerians will tell you, how sure are we that he actually took the right vaccine? And why is he or she saying that? Because in the last couple of decades, there is no trust between the people and the government, whereas element of trust between the people and the religious leaders and the traditional leaders. Again, if the Oba of Benin does the same thing, it comes out into the mainstream media to take the vaccine, that will send another strong signal to the followers. People like top rank churches like Bishop David Oyedepo, the RCCG, Redeemed Christian Church of God. So if these individuals come forth to take this vaccine, it's going to boost that public trust. So actually, the traditional leaders and the religious leaders as well they are actually the one leading Nigeria. The government is just there to maybe disburse cash, budget, and what have you. But Nigerians are able to communicate clearly with these individuals I've mentioned. So that is the angle the government should be going into right now, trying to convince these people, convince the National Union of Road Transport Workers president, convince the president of Okada riders. These guys have strong voices more than you, the government itself. So convince these individuals to come out to take this vaccine, then convince their followers. Then finally, what Nigerians should be doing right now is you could have a nationwide broadcast where you bring in experts, Nigerians basically, just bring in your people all around the world. Let them debate about these issues on national TVs. Let Nigerians connect. It could be a 2-3 days interviews. Let people start talking. Once you start hearing experts speak about these issues, it's going to as well boost the confidence you're looking for people to take this vaccine. Because my fear is this: I do not want us to get to a point where the majority of the world is safe. Then we then have Africa trying to get off the woods because we've kind of been sidelined when it comes to the vaccine, or even when we get the vaccine, our people are refusing to take this vaccine, basically. So we need to have this communication going and as fast as we can.
Very, very important, spot on there, Peter, because even from among the political class in Nigeria, specifically a governor of Kogi State in Nigeria has come up to say the vaccine is a ploy to assassinate him and his people. And he's still going about saying that there is not a single case of COVID-19 in his state. And if you move away to the southern part of Nigeria, specifically Edo State, the governor is already doing what you have just highlighted, talking to the NGOs, the civil societies, as well as the traditional people to help in speaking with the people, because Africa is more of a communal lifestyle than any other part of the world. But again, what's your take on the rapid diagnostic test kits? How is this different from the RT-PCR? And why the delay in deploying these kits in the early days of the pandemic?
The rapid test kits are slightly different from the RT-qPCR. So the RT-qPCR test actually tests for the genetic materials in your samples, whereas the rapid diagnostic test kit actually tests for antibody. Now, when you say why the delay all along, the delay is based on the fact that in the early days of this pandemic, since the virus was relatively new, there were no specific antibody test kits that could easily detect this particular virus or antibodies specifically, and they were not also sensitive. And that's where research comes into play. So you could see that in the last couple of 11 months, there have been research ongoing trying to optimize this RDT test kit to ensure that once you introduce a sample right there in studio, you could actually see if this individual is exposed to COVID-19, or if this individual has a virus or the disease ongoing. And how do you differentiate that? So if, for instance, you take your blood sample into the RDT test kit, you're going to have a few lines showing up. So if you have the IgM showing up, it shows that that particular individual has active infection ongoing. So such individual, you could then proceed. If you want to double check again, you could proceed for the RT-qPCR to check if that particular individual has a SARS-CoV-2 virus in his or her system. But if that particular test shows a line around the IgG, now the IgG is a little soldier in your body as well that helps to fight any form of infection that you are exposed to. So what that means is that the IgG antibody is the last form of defense when IgM fails. And if there is subsequent reinfection, it means that your IgG will kick in again to fight. So if the IgG line shows up, it means that that individual was previously exposed to the virus, but that particular virus is no longer active in that individual's system. So don't be surprised that in the next coming weeks or months, you're going to see NCDC ramping up their testing Now, this testing are two fronts. The first front is the RT-qPCR, which is gold standard. Then the second angle is the rapid diagnostic test kits. So very soon you're going to have the numbers going up quickly because we are using two platforms to actually test for this particular virus. And that is the right way to go right now. And that same test kits are easy to use. They are user-friendly. They are cheap as well. So it means that if you have the right test kits with you, News Central could literally test all of the staff on ground within 24 hours. That's how quick and fast it is when you have those particular test kits at your disposal.
We'll take a moment where we'll come back. We'll speak more on the vaccine and one other area you did raise, which is someone can get infected again even after testing negative. Stay with us. Home stretch here on VSA, looking at what the continent is dealing with. Currently Africa has over 3,000 cases of COVID-19 with over 80,000 deaths. That's a 2.4% case fatality rate, less than the 2.5% to 3% benchmark by the World Health Organization. So Africa may be faring well relatively, to Europe, Asia, and South America. Of course, this is believed to be a reason as to the low distribution of vaccines to the continent, other than the fact most African countries are not economically buoyant. AstraZeneca, Pfizer, Sputnik 4, Sinopharm, and recently Johnson & Johnson have all produced vaccines against COVID-19. So African countries like South Africa, Morocco, Egypt, Kenya, Guinea have all made arrangements for the procurement of these vaccines. But many are not thinking about it. Well, we'll still have Dr. Peter Imoesi in Aberdeen. Dr. Imoesi, good to know you're still there with us. But before we go, we dwelt much on the need for research funding in Africa. However, we've seen people sent to study abroad by universities and countries, and they never return. Some even prefer to repay the money spent on them. How, as researchers, will you deal with this if you were in the shoes of government?
I didn't get the very last bit of your question, please.
On the continent, we've seen some who were also lucky to have been sponsored, for such training by the government here on the continent, but they failed to return. How can the government, continue to have faith and trust in those coming, before those that have eloped?
It's really a big challenge. I've seen quite a number of Nigerians here that were actually sponsored by TED Fund. Now, TED Fund is a tertiary education trust fund that actually provides funding for lecturers for their masters and PhDs abroad. And when these individuals are done, they basically stay back, refusing to go back home. And for me, I think the whole idea is morality. So you should have a kind of a good moral compass to know that you have to do the right thing. And also, it also comes down to patriotism. So why will you take so much money from the government, and when you're done with the program, you literally refuse to go back home to contribute your quota to the system that provide that particular enabling environment for you to study abroad? So what the government could do basically is, well, they've done a few things. One is to create a bond, and even at that, people still kind of break those rules. So first, let the government write straight to the UK government directly if those individuals are in the UK, requesting that X amount of individuals were under our sponsorship. And because of that, we're meant to return to serve the country or their institutions after their PhD programs or master's program. Could you do something about that? And I'm sure any reasonable government anywhere in the world will comply to such requests.
Absolutely.
And now, the other angle that I have challenge with is when they return, for instance, do you have the enabling environment like the university where these individuals could actually use the skills they've learned overseas in the country? The answer is no. Now, I've proposed a few things here and there when it comes to upgrading tertiary institution in Nigeria. First, I know that for TED Fund, most persons, they do get up to 50 million naira, depending on the country you're going to, for their PhD programs. So what you could do is, if, for instance, you were to sponsor 10 individuals for this particular program for this year, you could say, we're going to sponsor 9. Then the 10th individual, we're going to use that particular money to build a standard laboratory for life science departments. Then the next year, that individual could go. Then you do another 10 again the following year. Now, the leftover money again, you could use that again to build a standard engineering laboratory for the engineering faculty. So you keep doing that over and over again in a couple of 5, 10, 15 years. So when your people return back home, all the skills they've learned overseas, they could actually use such skills in the country. And again, I think African scientists or lecturers within these institutions, they need to go back to the drawing board to think clearly how their research could be beneficial to the society and to the immediate university community. So I'll give you an example, for instance. What stops an engineering department from creating a solar system for the university? Because of course, we know we have challenges with electricity. So if you give a project to undergraduate students, master's students or PhD to develop a new approach or a new way of electricity and generation, that will be a research that will be beneficial to the immediate community, which is the university. And by so doing, the laboratory you're going to be developing over time will be powered based on your own system of power generation. And that will kind of be more like a collaboration between these departments of higher learning. So it's really a tough ride for the Nigerian government to send out a lot of persons overseas, and only a fraction actually return back home to contribute their own quota to the system. Finally, I would say that if you know fully well that you're not going to return back home, do not sign the bond. Do not take the money. Go sort for your own fund, or you could apply for scholarship and go out yourself. But so long you intend to go based on government funding, the right thing to do is you should return back home to fulfill what the bond you signed was all about.
So it's all about giving back and being honest about it. But again, quickly here, how expensive is it for a country to get the vaccines? Because as it is now, South Africa is already thinking of raising taxes to meet its procurement needs for vaccines. For now, South Africa has been able to secure just 20 million doses due to be delivered in the first half of 2021, but is looking to raising taxes to make more money for the next tranche.
So it depends on the vaccine you're actually going for. For the Pfizer, I think it's £25. Then for Moderna, I think it's £15. Then for the Oxford AstraZeneca, it's somewhere around £3, and that's about 1,000 or 2,500, which is really cheap. So what you could do is to go for the vaccine that is readily available and affordable by your country. So for me, if I'm in government, for instance, I should be heading for the Oxford AstraZeneca or the Johnson & Johnson. But just to say this clearly, the Johnson & Johnson and the Oxford AstraZeneca, they use a kind of different technology, which is the adenovirus. What that means is that you kind of weaken a virus, then introduce genetic material of this particular SARS-CoV-2 spike protein, and deliver that same vector or vehicle into the host, which is the human in this instance. But I think for the Johnson & Johnson, they use a particular strain of that particular adenovirus 26. The only fear we have now is Ebola vaccine was developed using the same adenovirus 26. And what may likely occur is most likely there may be a cross reaction where if the body initially recognizes that, oh, we had this particular type of vaccine before, but this is a different vaccine, but the same vehicle is used currently to deliver the vaccine, the body may react. And if the body reacts, it means that that particular adeno 26 that the Johnson & Johnson are using to deliver the genetic material of this spike protein into this individual may have a little glitch here and there. So, for instance, I think Democratic Republic of Congo, they have high rates of Ebola. So if they are going for vaccine, for instance, I would advise that they should look into, I'm not trying to market something here again, but I would advise that they look into Oxford AstraZeneca, for instance, because Oxford AstraZeneca, they're using the chimpanzee adenovirus, and that particular virus is rare. So it means that once you introduce that vaccine to those individuals, they won't create a cross reaction that will then weaken the efficacy of the virus, of the vaccine. So if African leaders are actually going for this vaccine, I would advise that you consult carefully with experts in this field. It's not about buying the vaccine. It's about buying the vaccine that will be effective within your own given population. So what works in Nigeria may likely not work in South Africa, and what works in South Africa will likely not work in Nigeria as well. So I think we need to put our heads together and create new ways and new approach going forward when it comes to vaccine procurement and development as well.
It's a fine place for us to say many thanks for being such a nice company, Dr. Peter Imoesi, a research fellow at the University of Aberdeen in Scotland, and of course Dr. Damaris Matuke in Kenya, Deputy Director at the Kenya Medical Research Institute, even though we just couldn't reconnect with her. Both of you have been awesome, enlightening the continent on what the continent and the world is dealing with. Well, availability, affordability, quality of these vaccines, as highlighted, are key issues that the continent can actually look into, and also the continent is not really sleeping at the moment, as all experts from across the globe are looking at how best to get the continent healthy. Once again, thank you very much. Well, Villa Square returns tomorrow. I'm Sulaiman. Bye-bye.